Welcome to the next part of this coronary angiogram and view series on YouTube. And what we are going to talk about is walking through each of the views individually and give a couple examples. So first up, what this video is going to be all about is RAO Caudal. We'll go over this animated image first, and then we are going to go through 3 different examples, and we'll talk about what you're looking at, all of the different anatomy, because before we were really just talking about LAD and the circ. And that is important to start there every time, but of course you do need to know the smaller branches, and we'll finally walk through being able to identify those. So again, first up, RAO Caudal. It's one of the 4 corners, and this is for the left coronary artery. So again, this is just an animated image first. We've talked about 2 different techniques so far. One you might be familiar with for RAO versus LAO is, okay, spine is on the left, so it's RAO, versus if spine is on the right, it's LAO. Okay, so here you see, this is my version of a spine. Spine is on the left, so it's RAO. And then when we talked about how do I know it's caudal, we looked at the U, right? Circumflex, U in circumflex. And although you can see both vessels, what you see best outlaid in front of you without a lot of overlap is the circ. Therefore, it is the caudal view. And then the other way we talked about being able to identify RAO was by the heart shadow. So remember, these are epicardial vessels. So if I trace out the heart shadow, this is what my LV-gram looks like in RAO. This is the anterior wall, so this is the LAD. This is the inferior wall, and this is, in the middle is the lateral wall. So again, that is the circumflex, and this is an RAO view. So again, just out of all the techniques we've talked about, whatever one works best for you, go with it. But we'll walk through the different ones and the different examples. So let's get down in the weeds a little bit on the rest of this anatomy. So first of all, we know this is the circ system, this is the LAD system. So let's talk about what is in which. Give me 1 minute here. So in the LAD, do you remember what, make this a little darker so you can see it, what branches came off the LAD? D was for diagonals. And then what else comes off the LAD? These little hair things. Those are septal perforators, or septals for short. And that's what you're looking for when after you identify, I guess I can't talk and write at the same time. Septal perforation, haha. Septal perforators. There we go. And then when you are looking at the circumflex, what branches come off the circumflex? And the circumflex has some different options, but the main one, right, this wasn't an O, but it was close to look like an O, is the obtuse marginals, or OMs. And then what sometimes can come off of the circ? Marginals. A PDA, right? And the PDA has septals, the posterior descending artery, if it's a left dominant or codominant system. So this image that we have does have a PDA. And then this would be OM, this one right here would be OM1, because we go in direction of blood flow, OM2, and then this right here is a PDA because it has septals, but if it didn't, you'd call that OM3. This is the proximal circ. And then this, it's going towards the AV groove. The AV groove is the distal circ. This right here, I know there's a lot of overlap here for the LAD, and that's normal in the caudal view because the caudal view is for the circumflex, right? So over here somewhere is the LAD, and then I will go ahead and tell you this is the diagonal one. And then these little hair things are the septal perforators, and you can designate proximal LAD, mid LAD, and distal LAD. And then this thing in the middle is a possible ramus. It's hard to tell a ramus in the RAO caudal view. You really need LAO caudal. So if we decided this in fact is not a ramus intermedius and it is an OM, then you'd rename these. This would be OM1, OM2, OM3. So remember, we can't identify absolutely everything in one view, and that's okay. So I hope that is a good solid foundation, and then we'll apply this foundation to some examples. So first example is going to be this still image, and then we'll work on some moving images. Now remember, I'm telling you this is RAO Caudal because those are the examples, but let's see. Now I know the spine is kind of out of the image, but it is over here, which is why we like a different tactic to be able to kind of trace the outline of the heart. It is kind of apically pointing this way versus this way is LAO, right? So this is an RAO view, which tells me that this vessel is the circumflex. This is our questionable ramus, and then this is the anterior wall, so the LAD and diag are up there somewhere overlapped on each other. And I did forget earlier to identify the left main. So again, we will go ahead and actually label these. And remember, this is diag questionable LAD. Sorry, let's do red. Red's a little easier to see. Diag or LAD. We have these hairs coming over here. Those are the septal perforators. This is proximal, possible mid, distal is out of the image. This is the questionable ramus intermedius, right? Or OM1. This is the circumflex. This is a possible PDA. We will need to see the right coronary artery before we actually call it that. And there are some tiny OMs here, and you can decide if you want to call those or not. Sometimes you just go with the most significant one first. So if this actually is a ramus, then this would be OM1. Okay, and again, if this ends up not being a PDA, although I'm pretty sure I see septals here, that would be OM2. And you do see a little bit of the continuation of the circ here. And then you have this anomalous vessel up here. And of course, your left main. Moving on to example 2, we do have a moving image over here, but I tried to take the picture where it is filling the most. And again, you do see where the catheter is and where the spine is, because this is a femoral approach, so you can see it in the descending aorta, and that is where the spine is on the left-hand side, so it's RAO. If you don't do it that way, can you kind of see the pericardial sac here, and you see the heart shadow, putting that in RAO, because that looks like your LV gram. And then, if this is RAO, this is the anterior wall, so what vessel is this one? The circumflex, because this would be the LAD. And we'll go ahead and label those out. And this one's a little off axis, which is okay. That's going to happen. These little hairs are the septal perforators. And again, we could call this long segment proximal, mid, and distal LAD, or again, not 100% if that's the LAD or a diagonal, because the apex is more over here. So that could be the LAD. But again, these are the normal questions you're going to ask yourself when you're in a view that is not for the LAD. And then you will confirm that in different views. This is the circumflex, right? So we'll call this the prox circ. And then possibly, well, that does kind of go, well, that is in the AV groove. So we'll call that mid to distal circ. This is the left main. Then you do see this kind of cut across here. I do see either septals or collaterals. It could be collateralizing something because this LAD, if it is LAD, is very, very small. So we could call this maybe the PDA, maybe an OM. And then these could be, again, we would need to see the other side, PL or OMs. But let's say the RCA is here and non-dominant. Okay, the RCA is here, very, very small. Then you could be comfortable calling this, you know, a PDA or a PL. But the patient does have small vessel disease, so that is very difficult to see. So you do the best you can with the information, you know, that you have at the moment. And the more diseased your patient gets, the harder it's going to be. But what you can do, let's go back an example or two here, and I'll bring this one over. If you know what, quote, perfect normal anatomy looks like, then you apply that to the diseased anatomy that you're currently looking at as a landmark to just figure out, okay, is anything missing? Are all of my main vessels here? Maybe there's some collateralization going on here, because I know the LAD should really be big and robust going along this anterior wall, and it's not. So is it maybe occluded somewhere? And then you start looking for those connections in other views, and you start looking for those collaterals to see if they're filling in the gap of a space that you're missing. And then this could very well be an OM, and instead of septals, these are actually collaterals. So yes, the picture-perfect angiograms that you practice are important to have a super solid foundation. So when you get something like this that isn't super picture-perfect, but you can identify the view, right? Because you definitely see the heart shadow, you definitely see the spine over here, you know this is the circ, you know this is anterior territory, so you know this is the LAD, then you fill in all the other gaps later on as you gather more information about the patient, you gather more views, and you start connecting those dots. Next up, example 3. So these are kind of hazy images, again, different image quality, but we can use the same principle. Spine really isn't in here at all. This is kind of the front of the chest, and you can kind of see that with some of the ribs, but can you see the heart shadow? You can kind of see this, the end of the kind of the pericardium here. So I can kind of trace this out as the heart shadow. And same idea, up here would be the anterior wall, down here would be inferior, right here would be lateral. So this is circumflex territory, this is LAD territory, and we can start labeling out. Maybe will blue do well here? Yeah. All right, so very tortuous, right? That's where we kind of call this lumpy bumpy for lack of medical terms, and kind of this snake curly fry like coronaries, which again makes anatomy a little hard to identify because this is circ territory, of course, but really the actual circ is probably here. So I'll call this the circ. This is more of an OM. This is also an OM because it's kind of coming off down in the circ versus right here for it to be a ramus. So you could call that OM1. You could call this OM2. And yes, it's the whole thing. Even though it does bifurcate down here, you're going by origin. So the origin of OM1 starts here, and everything else coming off of that is considered OM1. You might have a little bit of collaterals down here. And then up here is LAD territory. So we're going to call this prox LAD. I believe the septals are originating up here, which makes this up here the mid LAD, down here the distal LAD, and really you should be writing these out. I'm just doing it for time. These are the septals. Okay, septal perf, septal perf, septal perforators. That means this is the diagonal, although you can't see the origin really well. Okay, there might be other diagonals, but you can really only identify one in this view. This is a super short left main, but there is a left main there. And there you go. So I hope that helps. And again, as we navigate these, not one view is going to be completely perfect for every single branch that you see, and that is okay and that is normal. That's why we take multiple views. If you have some type of missing piece of information or isn't really going where you expect it to go, then you start to look for those collaterals, you start to look for little abnormalities or late filling here and there. Stay on fluoro a little longer so you can see the rest of the filling, and that's where you might see the collaterals coming in to perfuse distally of a segment that you might be missing. So that's RAO Caudal. Next up, we're going to talk about LAO Caudal, and the same thing. We'll have a perfect anatomical image and apply that system to some different angiograms. Thank you so much for being here. Like and subscribe so I can make more videos like this in the future.